going to skip that as well because I really wanted to talk a little bit about control banding, and I don't want us to run out of time for you guys to go back in and spend a little bit of time talking with each other before we finalize this. So basically, this is just a summary again. I tell people, think of this as many mobile point sources, lots of exhalation, large and small particles. Certainly the concentrations are higher in the immediate vicinity of the source, but you will get distribution all throughout the space. And we don't have an exposure limit. And so that's the big problem with this organism, is we really don't know what the dose, anything, we can't tell you much about dose. We do know that probably dose plays some role. Well, in the context of infectious organisms, we've been doing pandemic influenza planning for many years, and Margaret Sietsema, who's a student of mine, now works at UIC as an industrial hygiene faculty, and I and some colleagues from CDC and NIOSH published this article about control banding for aerosol transmissible infectious diseases back in December, surprisingly, and it was very timely, unfortunately, for this pandemic. And we proposed a sort of qualitative way of determining risk, and we tried to come up with something simple that people could use to determine who's at higher risk and which jobs are at higher risk. We basically allocated exposure into likelihood times duration. Now, exposure really is concentration times time, but this was likelihood is how likely is it that you will encounter one or more people, and duration is how long do you spend in contact with people who are potentially infectious. And those combine to be sort of a qualitative band for exposure. You then add that exposure ranking to a rank for risk. And these are based on the NIH biosafety level risk groups. And SARS-CoV-2 is a risk group 3 organism, which means that it is associated with serious or lethal human disease. And there are not very many preventive or therapeutic interventions at the moment. So, but there may be a few. So it's not as risky as Ebola, which is a risk group 4 organism, for which there are no real therapeutic treatments and no vaccine. R3 is a little bit less risky, but doesn't mean it is without risk at all. And then I designate based on exposure rank what in this combination of risk rank, what your control band is. And just reminding you, this is all guided by the same hierarchy of source, pathway, and receptors. The control band then gives you a way of thinking about, well, what should I do? If I'm in control band A, which you may recall is some of the lower risk and lower exposure possibilities, then certainly you do source control first, and pathway controls might be prudent, but you should be working very hard not to use receptor controls because they shouldn't be necessary. If you're in control band B, higher exposure, you certainly should focus on source and pathway, but we added a caveat that you might need multiple options, multiple of each of those. And eventually you may come to the point where receptor controls are needed, but only if you can demonstrate or if you believe that source and pathway controls are not adequate. And finally, you come to pathway control band C, and of course, all healthcare, frontline healthcare workers would fall into control band C with very high exposure probability and duration. This is certainly do source control, and there's lots of source controls in healthcare settings. It might require multiple ones. Pathway controls as well, and then but at this point, receptor controls are probably prudent, and that is what CDC did say about SARS-CoV-2 care for COVID patients is healthcare workers should be wearing respirators. I'm going to give an example of how to use this in the context of a job. So I have a city bus driver, for example, and transportation workers have been shown to be at high risk for infection. They are considered essential workers, of course, so many of them have had to work through the pandemic. They do interact with many people, and those people may be infectious, and it would be very hard to know which ones were not, so you have to assume each one is, and many could be asymptomatic. They work typically 8 to 10 hours a day. So the exposure it's a possible exposure, although you could possibly move it to a likely exposure, but at least a possible exposure in their longest exposure time. So this pushes them into an E3 exposure. And that control band C requires you use multiple source and path controls. Well, source controls are not easy, although some of the Asian countries are doing immunity testing and giving people passes before they're allowed to step onto a bus, and they do screening. We haven't necessarily resorted to all of that with transportation. And I will remind you that face coverings will not limit emission of the smaller particles. I don't personally say that the public should not wear face coverings. My message has been, please don't count on them and don't spend too much time near people or in an enclosed space if you only have a face covering. But certainly the worker should, that's the source control. Pathway controls, well, the best pathway control I can come up with in a bus is that the bus driver should be sitting in a separately ventilated enclosure, because this is a small space. Turns out most ventilation in a bus comes from back to the front. So that's like the worst situation. All the particles are directed towards the bus driver. So really they need to be enclosed. And bus drivers shouldn't have to wear respirators unless they have to exit that enclosure and come in close contact with customers, which may or may not be required given their jobs. So in this case, we did say receptor controls in limited situations. I have another situation of a physical therapist. Again, lots of direct contact with a lot of people, some of whom may be asymptomatic. In this case, I said, well, let's think that probably they're going to be likely exposure of many of these people could be asymptomatic. Again, this will depend on what the rates of infection are and case rates and death rates are in a particular area. And then their exposure is for most of the day or most of their shift. They also have an E3 exposure, and certainly you can be screening patients for symptoms and contacts. You could be testing patients before they come into contact. And I would suggest that patients should be wearing surgical masks, not face coverings at a minimum, as source control, because they offer better filtration and a little bit better fit. And path controls, if you can work with patients at a distance, but more likely you'll have to rely on room ventilation, portable air cleaners perhaps, and just having fewer contacts with people. So changing the shifts, changing the nature of work. And it is possible in this case that the worker should also be wearing a respirator. And 95 filtering face piece respirator would be the minimum. So with that, I'm going to send you guys back in. Let's see what time.